Let's be honest, interpreting an arterial blood gas, or an ABG, can feel like one of the most intimidating things in medicine. But what if I told you it's not a test, it's a puzzle, a code? And you know what? In the next few minutes, we are going to crack it together. Because that is exactly what an ABG is. It's not just some random set of numbers. It is a direct message from a patient's body telling us precisely what's going on with their acid-base balance. And today, we're going to learn to read those messages loud and clear. So to crack any code, you first have to know the key players, right? Well, there are three main values on an ABG that tell us almost everything we need to know to figure out the primary problem. Okay, this right here, this is our decoder ring. This is the rule book. Everything starts with knowing these normal ranges. For pH, it's 7.35 to 7.45. For PaCO2, think 35 to 45. And for bicarb, or HCO3-, it's 22 to 26. Commit these to memory because we're going to be using them a lot. First up is pH. Think of the pH as the ultimate judge of the body's balance. It gives us our first and most important clue. Is the body too acidic? We call that acidosis. Or is it too basic or alkaline? That's alkalosis. The pH tells us immediately which way that scale has tipped. Next, we've got PaCO2. This is our respiratory clue, and it's all about the lungs. Now, here's the key thing to remember. CO2 acts like an acid in the body. So if you're breathing slowly, you hold on to CO2, and the blood gets more acidic. If you're breathing super fast, you blow it all off, and the blood becomes more alkaline. Simple as that. And our third key player is HCO3-, or bicarbonate. This is our metabolic clue. Bicarb is a base, and it's managed by the kidneys. Now, unlike the lungs, which can make changes in minutes, the kidneys are the slow and steady players in this game. They take hours or even days to help fix the balance. All right, so we've met the players, we've got the rule book. Now let's put it all to work. I'm going to give you a simple, repeatable method. This is your key to cracking the code, every single time. It honestly is this simple, just 3 steps. First, always look at the pH. That tells you the main problem, acidosis or alkalosis. Then, you just play detective. Step 2, look at the PaCO2. Does a lung issue explain what's going on at the pH? If not, no big deal, move to step 3 and check the bicarb. Does a kidney or metabolic issue fit the crime? One of them has to be the primary cause. Okay, ready to put our 3-step key to the test? Let's apply it to the 4 main types of acid-base imbalances you're going to see. Let's see how this thing works in action. Our first pattern is respiratory acidosis. And you know what? The name pretty much gives it away. The problem is respiratory. It's caused by hypoventilation. That just means breathing too slow or too shallow, causing the body to hold on to that acidic CO2. So let's apply our method. Step 1, the pH is low, so we know we have an acidosis. Step 2, we look at the PaCO2. Whoa, it's high. Since high CO2 means more acid, this perfectly explains our low pH. Boom! We've found our cause. It's respiratory. So what kind of things cause this? Really, anything that slows down breathing. The classic example you'll see is a patient with a COPD exacerbation, but it could also be from an opioid overdose or a really bad asthma attack. Now let's flip that on its head and talk about the exact opposite, respiratory alkalosis. Here, the problem is hyperventilation. The patient is breathing way too fast, blowing off too much of that acid, CO2, and that makes the blood too alkaline. Let's run the steps again. Step 1, the pH is high, so we know it's alkalosis. Step 2, the PaCO2 is low. Well, if we're blowing off acid, a low CO2 level makes perfect sense for why the pH is high. See? The problem is respiratory. The most textbook scenario here is a patient having a panic attack, breathing really, really fast. But it's not always anxiety. It can be caused by pain, being at high altitude, or even something really serious like a pulmonary embolism. Okay, let's switch gears. We're moving away from the lungs and over to the kidneys. Metabolic acidosis happens when the body either loses too much bicarbonate, remember that's our base, or it gains way too much of some other kind of acid. Let's put on our detective hat again. Step 1, the pH is low, so it's acidosis. Step 2, we check the PaCO2. If this were a respiratory problem, we'd expect the CO2 to be high. It's not. So we move to step 3 and check the bicarb. And there it is. It's low. Since bicarb is a base, losing base absolutely explains the acidosis. This is a metabolic problem. The absolute classic example here is diabetic ketoacidosis, or DKA, where the body is just churning out excess acids. You might even see these patients taking these deep, rapid breaths. We call that Kussmaul breathing. And that's a huge clue. It's their lungs trying to compensate, trying to blow off as much CO2 as possible to fight that metabolic acidosis. And that brings us to our final core pattern, metabolic alkalosis. This one usually happens when the body loses way too much acid, which leaves an excess of base hanging around. All right, one last time with our method. Step 1, the pH is high, so we know it's alkalosis. Step 2, we check the PaCO2. Well, a respiratory cause would mean a low CO2. That's not what's happening here. So, step 3, we look at the bicarb. It's high. An excess of base perfectly explains why the blood is so alkaline. It has to be a metabolic problem. So, what's the most common cause? Think about losing stomach acid. The classic scenario is a patient who has been vomiting over and over, or someone who's had an NG tube suctioning out all that hydrochloric acid from their stomach. So we've cracked the 4 basic codes. Not so bad, right? Now we want to give you 2 incredibly powerful tools that are going to put all of this together and make interpreting ABGs even faster. And that brings us to the most famous trick in the book for ABGs. It's a little mnemonic that will save you so much time. ROAM. It's this simple. R is opposite. That means if the problem is respiratory, the pH and the PaCO2 will move in opposite directions. M is equal. If it's metabolic, the pH and the bicarb will move in the same or equal direction. This is your go-to quick check every single time. And here it is, your master key. This chart puts everything we've talked about all in one place. Just look at the patterns. For respiratory acidosis, see how the pH arrow is down, but the CO2 arrow is up? They're opposite. Now look at metabolic acidosis. pH is down, and the bicarb is also down. They're equal. See how ROAM just plays out perfectly? You can use this table to quickly spot the pattern in any ABG and link it right to a classic cause. This is your ultimate cheat sheet. So just remember, an ABG isn't just a lab value, it's a story. It's the patient's body trying to tell you exactly what's wrong. And now you have the key to crack that code and finally understand the story. So the next time you see those numbers, you'll be ready to listen.